Welcome to the Wheeler Institute for Business and Development COVID-19 seminars. This is the fifth in the series run by the Wheeler Institute that is focused on the UK economy, and this promises to be a particularly unique one. The focus here is on the UK NHS, and specifically on management practices and management within the UK NHS. We have a terrific group of panelists with us. We're delighted so many of you have been able to join. Our panelists today are Professor Sir Andrew Likierman, Professor of Management Practice at London Business School and the former Dean of London Business School, Professor Raffaella Sadun from Harvard Business School, who's a professor in the strategy area at the Harvard Business School, and Professor Nicos Savva from the Management Science and Operations Group at London Business School. Andrew and Raffaella and Nicos are well renowned for their work on healthcare operations and healthcare management and managing healthcare organizations more generally. And the exciting thing about having us all together is the opportunity today to go beyond the headlines, go behind the scenes and understand not only those big stories about outcomes or lack thereof, or as well as inputs around how much funding went in, how many buildings were built, and how many beds exist, but the actual day-to-day management practices and indeed strategies that National Health Service organizations engage in. That could make a huge difference in how we not only manage this current pandemic, but also potential future waves or indeed healthcare challenges in the future. So that's why I'm particularly excited to welcome this very distinguished group. My name is Rajesh Chandy. I'm one of two academic directors of the Wheeler Institute, and I will be playing host today. So with that as introduction, let me hand things over to Andrew Likierman. Over to you, Andrew.
Rajesh, thank you very much indeed. So just to be clear, my comments this morning are in the context of making judgments in organizations. That's the work I'm doing at the moment, and in particular in relation to complex choices. And as we all know, these are very complex choices. What I've done for this webinar is to talk to a number of NHS managers to inform the comments and suggestions I've got, and to make sure that what I'm saying look as if it's realistic in terms of what's going on now. And I'm going to focus on the future rather than the past, because of course the past is relevant in helping us in terms of what we're going to do in the future. But I don't want to simply focus on what has happened, because the key questions for us are, what do you do now? We are not through this yet. And in particular, what do you do with a second wave? So in terms of what I want to focus on, the judgment aspect, I've been working on a framework for judgment, and I'm going to focus this morning on the question of experience. What do we know in terms of the background which informs our decision making? And I'm going to look at this in relation to what's going on at the moment in the NHS. And just to be clear, there are obviously terrific examples around the world about what to do. And I'm very much hoping that the UK NHS is going to look at best practice everywhere. But right now, I want to try and be more precise about what they should do in relation to the framework that they've got and the experience that they've had, so that they can get the best out of that. So in terms of the relevant experience, it seems to me there are three aspects to this. First of all, what's gone on at a national level. Secondly, what's gone on at a devolved level. And thirdly, the areas where we've still got things to learn. Let me take the national level first. And here there are two areas, it seems to me, in which we not only have lessons in terms of a second wave and coping with that, but also long-term implications for the NHS. The first one is about collaboration between different bodies. What we've seen is a degree of collaboration that many would have thought difficult, if not impossible, between bodies that traditionally had operated rather separately. And I think this is a great opportunity to reinforce the links that have been made, the way in which people work, to try and make sure that these are kept after COVID-19 hopefully is long gone. The second area is in the area of artificial intelligence and remote working. It seems to me here too, there has been a breakthrough, as there has, of course, been in many other fields, in terms of what is acceptable and what is normal in the application of artificial intelligence. And this seems to me to have the potential of saving a lot of time and a lot of effort in a rather traditional kind of way, as well as enhancing the sophistication of what the NHS has to offer. So these two elements of what we've learned, it seems to me, have long-term implications. There are two areas also at national level where we've learned in terms of the second wave. One is in terms of equipment, PPE, ventilators, emergency provision of hospital beds and so on. So we know a lot more now than we did then, and this is clearly an area to build on to make sure that we hang on to that and understand what the implications of that have been. And the second area is about staff conditions. Now, when I talk to people in the health service, this is not something that necessarily people outside the health service would focus on, but they are very, very keen on trying to learn from what we know now about making sure you can keep people at work in terms of the conditions they have in which they operate, and the provision they have at work in terms of their working conditions. Now, that kind of notion of here are a heroic bunch, as it were, who have been given every facility, that of course will fade as, you know, as the crisis goes, but there are lessons to be learned from that. So that's at a national level. At a devolved level, there are, it seems to me, huge potential earnings here. But I am very concerned because there doesn't seem to be any systematic way that I've found in which the best practice can be transmitted around the NHS. So we've got good practice in individual units, in individual hospitals, in individual regions, but actually I don't see any way at the moment of getting that really into the system and, as it were, you know, cooked in to the way the NHS is going to operate in the future. And I wonder whether the one way in which this ought to go forward is making sure that NHS staff are fully involved in the way in which these things develop, in the way that my colleagues in the organisational behaviour area suggest they should at times of great change. One other thing I just want to say about the question of the devolved responsibility and learning there is that we know that we went into this crisis without precedent. So nobody had been through anything like this before. In the UK, as we now know, SARS and MERS gave countries that had those an advantage in a terrible kind of way in understanding what to do. And I just want to reinforce the fact that my work on judgment shows that people tend to take inappropriate analogies. And the danger, it seems to me here, is having gone into the first wave with no experience and understandably, therefore, not knowing quite what to do. The danger is that we will go into any second wave thinking it's going to be just like the first, which it won't. So I'm hoping that's not going to be an analogy that people take. Last then on things that we've still got to learn. We still have not yet understood, I think, how we reintegrate non-COVID patients into the hospital service, you know, how that's going to work, how quickly things restart. We still have to learn about using performance measures better. At the moment, we've had some rather inappropriate performance measures used and switched, you know, too late to other ones. That again is something where I think we've still got learning to do. We've had data problems. All over the world, it's the same thing. We've got big issues on what exactly do the numbers mean. And on the management of risk, this is surely something which we now have got a better basis for understanding what the trade-offs are. you know, the spare beds available for any new wave, the capacity of staff for such a new wave, how we protect the staff, how that coincides with winter flu in the Northern Hemisphere, and the resources available, because governments are not going to have an open tap indefinitely. And so that is also, it seems to me, a risk. So those seem to be the main areas there. And the messages, as far as I'm concerned, are the NHS needs to capitalize on an almost unique moment. Unique because you've got big barriers in terms of cultural barriers, which are currently down, and therefore the opportunity is there for change. And also with funding, and the NHS is currently on the moral high ground, and governments are more willing to fund things. I do hope the NHS takes this opportunity to use those two to achieve lasting changes. And having said that, I'd now like to hand over, if I may, to Raffaella.
Thank you, Andrew. And it's a pleasure being here with all of you today. I have to say we did not coordinate on what we would say in our 8 minutes, but although I come from a very different background and different experiences, you will see that I will touch on many of the points that Andrew has already raised. And just to give you a sense, I'm an organizational economist, and I've studied management before the pandemic. And in my research, what I discovered is that there is a lot of heterogeneity in the adoption of basic management practices across hospitals, and that this heterogeneity matters for clinical quality. The other point that comes from my research is the fact that you really want to focus on those middle layers of the organization. It's not enough to change the top of the organization to achieve sustainable change in a complex setting such as the one of hospitals. So I come into this discussion asking myself whether there is a role for management during and after the pandemic. And I reflected on this question, and I believe that the answer is a very strong yes. First of all, let's clarify that this challenge that the pandemic created is enormous. We are talking about a demand shock for services under severe supply shortages. So this is something that has been very hard. At the moment you have a surge for a complex organization, this demand surge is really incredibly hard to manage. Of course, a lot of attention so far has gone on to the negative part, which is this surge should have not happened in the first place. It's been by many as a management failure at the top of many countries, not just the NHS. However, I want to focus very much, as Andrew did, on the unexpected positive news that came from this experience. Of course, we have a debt of gratitude, and it's been emphasized in many outlets and many countries, the heroic efforts of doctors and nurses and clinicians more generally. I want also to emphasize that not only the clinical and the nursing staff has given 150% during this pandemic, but they've also demonstrated some unexpected and really quite amazing organizational capabilities and managerial capabilities. Just to give you an example, you can think about one specific example that I read a lot about is the hospital of Lodi in Italy, which was at the epicenter of the pandemic. Within 8 days from the first recognition of the crisis, the hospital changed completely the organization of not only the clinical procedures, but also staffing, how teams were composed, how they were going to communicate with each other, all those series of managerial levers that we've for a long time have taken as given or very hard to change, very inertial. What we've seen here is that there is really tremendous opportunity for change when change is needed, and when the clinical staff and the nursing staff believes that this change is important for quality outcomes, for patient outcomes. My sense is that we've seen this happening across different hospitals and different organizations. Think about the problem solving that had to happen for clinical procedures, how the hospitals have dealt with shortages of staff, again, how they've combined teams that were often composed by specialists, but also people that had never had experiences, for example, in handling ventilators. All this, I think, is really a promise, probably, that something can happen to improve management in hospitals when it's needed and when staff believe that it's important. Now, on the other hand, of course, these type of efforts and this type of improvements, although it's too early, we don't have data yet, and I'm a data person, and I'd love to see information that is, large scale and quantitative as much as possible, but we don't have that. We have anecdotal evidence. And right now, the anecdotal evidence is telling us that there has been a tremendous heterogeneity across hospitals. And so where we've seen this emergence of great practices, probably there has been other organizations that are still lagging behind. And in part, it's because we haven't done a great job so far. We've been in survival mode. But right now, it's a moment where we need to put all the knowledge that has emerged in the different hospitals and transmit it in a more standardized and coordinated way. And as Andrew was saying, we still don't have mechanisms that allow us to do this very quick and comprehensive dissemination of knowledge. So I'm going to conclude just by giving what I think are the priorities for the future. For sure, there is a reflection that needs to be made managerially in terms of the architecture and the organizational architecture of the system. We need to think more carefully about the actions and the decisions that need to stay at the central level. Procurement is one of them, probably information technology and the decision on how to deploy testing. These are all decisions that have strong economies of scale, and they probably need to be assigned and properly to the center in order to have to be more responsive. It's also clear to me that there needs to be a much more intensive effort in terms of fostering management practices for those middle layers. And I want to insist on one specific set of practices, which is practices that relate to staff, HR management. We are going to face a moment in which staff already is, and it's going to be even, I think, there will be shortages of staff. The clinical staff is exhausted. There is not much room for wage increases because we have a budget constraint, obviously. And we're probably going to see more temp staff. So this means introducing into the hospital staff that doesn't have the same amount of familiarity as the nurses and doctors that are already employed by the hospital. Plus, there will be, hopefully, remaining from this pandemic is the use of information technology. And we know that information technology is not just something that happens, the productivity effects don't happen by themselves, but they need investment, they need organizational change, they need management practices. So my hope is that we're going to have much more reflection on investments in management, probably also thinking more carefully about who gets to be a manager and how we train people that want to be a manager. There's going to be a need to combine technical and clinical expertise with administrative expertise. And we need to make sure that management is not a punishment for clinicians, and it's not something that they do because there is a pandemic, but they do because that's in the best interest of the patients. I'm not sure that we are at that point right now. And finally, to conclude, one area that will probably help improvement and will probably help us understand also what works and what doesn't work is measurement. At this moment, we have a fairly good sense of the tangible capital that goes into the production function of a hospital, into the production of care. But we really lag behind in the measurement of the intangible capital, the processes that help staff do their job and disseminate information, continuous improvement and all that. So my sense is that if we want to change, we also need to take much more seriously this measurement of intangible capital and managerial capital in the hospital setting. And with this, I am going to pass the mic to Nicos.
Thank you, Raffaella. I think technology is now working. It's a great pleasure to get to spend this next hour with you, talking a little bit about the COVID-19 crisis and what it means for hospital management. So a little bit about my background. I often describe myself as a data scientist who has found a home in a business school, or depending on your perspective, maybe hiding in a business school. I've been a professor at LBS since 2008, and for the last 5 years, I've held an honorary appointment at Guy's and St Thomas NHS Foundation Trust. I put a picture for you of patients treated by Guy's and St Thomas with a nice view at the background. And I also have a research collaboration with Imperial Medical School, which is focusing on the impact of COVID-19, which I'll talk a little bit about during this talk. In a nutshell, my research is about using data science and economic theory to improve healthcare management, both the delivery of care within hospitals, but also the regulation of care at the national level or at the payer level. So let me start by asking you a question. What do you think when you see a hospital? So most people would probably think of patients, nurses and doctors, medical equipment, operating theaters, hospital beds, maybe bad coffee sold via vending machines. And all of this is true, except maybe the bad coffee that's also improving very quickly. What do I think when I see a hospital? Well, I think of network flows. So let me give you a schematic. So this is the representation in my mind of the acute care pathway of a major UK hospital. So this is the pathway that starts at the emergency department. And for this particular hospital, there are about 382 patients arriving every day. That's about one patient every 4 minutes. Now, most of these patients go home, but some of them are admitted either to an observation unit or an admission unit, and depending on their needs, they may even be admitted in wards where they spend a longer period of time to recover. Now, every arrow represents a patient flow, but in a parenthesis, I also have the variability around these flows. So not only do we have patients traveling from one direction to the other, but there's also a lot of variability around these numbers. Now, obviously, this is a representation that can be applied to other parts of the healthcare system, for example, elective care, not just emergency. And it's clearly an oversimplification of what a hospital is, what a hospital does, and what it means to be providing care at a hospital. However, I think it's an immensely useful simplification. Why? Because it allows to use data science to optimize things like patient experience, efficiency, and even resilience of the hospital system. So example of this could be sort of bed capacity allocation, or staff optimization. These are things like how many beds do we need at different points in the hospital on this pathway, and also how many staff, being physicians or nurses of different capability, do we need at different times of the day. With using this framework, one can come to a situation where you can start making decisions that are objective as opposed to subjective and experiential. They are precise as opposed to based on trial and error, and they are also scalable in the sense that not every hospital has to reinvent the wheel every time. What works well in one hospital, subject to some local differences in constraints or resources or objectives, can be adopted and be used by any other hospital, something that both other panelists touched on. Going to the specifics of COVID-19 and using this data science view of providing care, I wanted to share with you some findings from work I am currently involved with Imperial College Medical School around the impact of COVID-19, not so much on the patients that have COVID-19, but on cancer care, and in particular colorectal cancer care. So care of cancer has been totally disrupted by COVID-19. since the end of March. And it was done so to preserve intensive care unit capacity and ventilators for patients that may develop COVID-19 symptoms and need this additional support, but also to protect patients that are vulnerable, and cancer patients are really vulnerable. So, but because the cancer care has been disrupted, there's a delay in cancer detection because fewer patients are being screened, and treatments will be modified or postponed. And both of these would lead to worse patient outcomes. But they will also lead to a backlog of both screening and treatments. And this backlog needs to be somehow processed once we return to something that resembles normal. And this is not easy because the system was working near capacity before the crisis hit. So asking a system that's working at capacity to also clear the backlog that's going to be created from sort of a few months of disruption in activity will not be easy. So to try to assess the implications for patient outcomes, but also to try to estimate the additional resources and come up with a plan to deploy the additional resources needed to deal with this backlog. A research team involving cancer specialists and operations experts based both in the US and the UK has tried to assess this. And let me share with you a few findings. So we asked the hospitals in a survey about 20 questions as to how COVID-19 has affected the care. And the questions can be sort of thought as diagnostic availability, oncology provision, and treatment decisions. And we ranked each hospital from 0 to 1, 0 meaning no disruption, and 1 meaning complete departure from clinical guidelines. As you can see, most hospitals have departed, at least to some extent, from clinical guidelines. And the data divides the hospitals neatly into 2 clusters, one cluster where hospitals have been greatly disrupted and another where they have not been so disrupted. And this is how they split, they appear geographically. But looking into sort of some more details on the actual number of treatments, what we find is that for screenings, we were expecting to see something around 38,000 screenings done nationally per month in March and April. And although March is close to what's expected, April is experiencing a 50% reduction in screenings. And similarly for treatments, even though something like 2,800 treatments were expected to be performed, this is surgeries, due to colorectal cancer, the number that was actually performed was 20% lower. So in a sense, these are the first steps to us trying to figure out how much impact COVID-19 has had and trying to come up with a plan to put resources so that we can catch up with this shortfall in both screenings and operations as quickly as possible. So I'll leave it here and pass on to Rajesh so we can open the panel to questions. So thank you.
Thank you very much. Thank you, Nicos, Andrew, and Raffaella. Since we've had about half an hour of sort of this overview of each of your perspectives, it's quite striking to see some of the common themes as well as the unique perspectives you each bring. Nicos as an operations person, Raffaella as an organizational economist, Andrew as an expert on judgment and accounting. Andrew, I thought there'd be a lot more discussion of accounting practices, but clearly both your new research and the spirit of the times were reflected in your comments about judgment and organizational and the challenges thereof. One question for, and perhaps this is a good moment to ask this question. One of the questions from a participant, Anushri Singhal, is, given everything you've seen and you've commented, if you can sort of summarize, what are the key learnings from this pandemic that should be implemented in hospital management on a permanent or non-permanent basis? If you could just summarize some of those comments. Some of you sort of laid it out more directly than others. Can I, Andrew, since you went first, if you had to pick like one or two important learnings that you would take away that have either permanent or semi-permanent implications, what would those be?
Rajesh, I mentioned, I think, two that were permanent as far as I was concerned. One is about collaboration between different bodies, and the other is about the impact of AI. But if I could just pick out, a couple more from the rest of what I said, I'd say also that perhaps on risk management, that's another area, it seems to me, potentially, where a lot can be learned. And perhaps I'd also pick out as it were, the relations with staff as being another important area.
Yeah, which is something I know Raffaella emphasized as well. Andrew, before we go to the other panelists, can I probe a little deeper there? So when you say collaboration across different entities, can you elaborate a bit or give us some examples of what should happen?
Well, all right. So virtually the only moment of real glory, as it were, which was identified, was the building of this hospital in London with 9 days. Now, clearly that demanded collaboration with many different bodies, which normally would have found it very difficult. They've gone into committees, they would have had to decide things and so on. So I think it's that kind of example, but in particular, I'm thinking of local government, local authorities, and obviously the care home sector. These are the kinds of links that I think have been forged during this pandemic that were not necessarily there before. That's what I meant by collaboration.
Got it. Thank you. Raffaella?
Yes, I would say that this pooling of resources that has happened across organizations and within hospitals is definitely something really important. It's one of those instances where, as we were talking about, economies of scale really matter. And it's been remarkable how these invisible barriers that often make pooling difficult have come down quite quickly, really. The second piece, I think, relates to how people... Sure.
Can I just, before you move to the second piece, just ask on that, the pooling. Again, so what is an example of pooling of resources? Do you mean across hospitals? Because there's a question on that. Is there a way to, for example, more quickly resource staff across hospitals? Or can you elaborate a bit on the pooling of resources before you go?
Absolutely. So what I have in mind is a pooling of equipment, for example, ventilators and those instruments. And then I think that there has also been an attempt to pool resources at the staff level. I know more of that in the US than in the UK, but that's in a situation of high uncertainty, where you need to reallocate resources quickly. Those type of actions actually can help a lot. So
employees you mentioned may also do that.
Absolutely. But the second piece, I think, relates to how people have worked together. A hospital is a multi-specialist, multi-dimensional place. And often, look, when I teach in my executive education courses, sometimes I had to separate doctors from administrators or cardiologists from orthopedicians. So, sometimes there are some strong feelings within the hospital. I think it's fair to say that in this instance, the patient needs have really taken off. They've always been, but it's been so clear to me that patients' needs were on top of mind. And that, I think, has enabled a collaboration that is across different specialists. And within specialists, my sense is that the sense of hierarchy that often exists between doctors and nurses, in many instances has, evaporated. Yeah. Now, I don't want to say, I don't want to sound Pollyannish. I'm sure that there have been also places where this did not happen. But the fact that this has happened is, I think, really something that we should recognize and celebrate and build on. Now, I want to say also there are practices that perhaps we still have a lot to do still in terms of learnings. And the issue, for example, of recognizing that there are complementarities between physical and human capital, the fact that it's not enough to move a ventilator, but you also need to have people who know how to use a ventilator. This sounds obvious ex post, but again, because we are so focused on the capital, on the tangible capital that goes into hospitals, we often, I think, lose track of all these other aspects that have to do with the intangibles.
Very good. Thank you, Raffaella. Nicos, please.
If I was to choose one thing that I think that should stay is our awareness that a lot of sort of important decisions need to be made on the basis of rigorous evidence and models. So epidemiological models were something sort of, so niche. I mean, most people didn't know what it was as sort of, 6 months ago or 4 months ago. Now, sort of, we talk about epidemiological models on the newspapers and on the sort of BBC News, for example. Other providers also exist every day. So one thing that I would like to say is our sort of comfort to rely on models to make such decisions as opposed to sort of, expert or not so expert opinions.
I'd say I found it striking when the Prime Minister gives these updates. He talks about the R needs to go below 1, and everyone's like, of course the R needs to go below 1. I had no idea what R was until a few weeks ago. So now it's like, yeah, so it's music to the ears of modelers like you, Nicos.
Totally, and I think epidemiological models are kind of the tip of the iceberg. I mean, once you know that there's going to be a surge in demand, this opens up all sorts of questions. I mean, how do you allocate additional resources to combat this surge? What do you do to sort of the hospitals that are going to be overwhelmed because their capacity is not going to be enough? And the more long-term ones, you deal with the crisis. How do you prepare better for a second wave? How do you prepare for treating the backlog of activity that has been cancelled because of the crisis? So forth. All of this, I think, could be better informed by models, and my hope is that this will be easier to do in the future.
So there's a related, actually several related questions. One from Sangeeta Raju Webb is, the NHS is very good at responding to serious acute care. And this was true even before COVID. They should say, oh, if you have a serious problem, don't go to private clinics or anything else, go to the NHS. But going forward, the challenge is going to be, says Sangeeta, the challenge is going to be processes to catch up with the backlog on top of the usual workload. Nicos, you alluded to this. Are you seeing good evidence that this sort of business as usual or daily, often mundane things that are not as sort of urgent, are you seeing evidence that this is starting to happen? Is there a real risk that this will not happen and that we can envisage, and what can we envisage would happen in the worst case scenario? So when the crisis is over, are we going to go back to, non-crisis mode, which would be less effective?
Well, I think that is precisely what I'm worried about, and that is the danger that, we have had a crisis, we've got through the crisis, and now we just go back to doing everything exactly as we did before. So I very, very much hope that will not be true, because the NHS has not had a great history on embracing change very often. It's quite resistant to change. It's quite bureaucratic. Everybody blames everybody else for the fact that things are quite slow. So I very much hope that won't be the case. In relation to the backlog, I think the jury is still out here. We just don't know. I mean, I've talked to some people and, they are still grappling with the business of what do you do with this backlog exactly? So I don't think we have the evidence yet on how good that's been. And that's why I put it into the category of still learning.
Raffaella, can you talk to that point about, developing a new way of managing? You mentioned the importance of middle management. So what interventions can either policymakers or hospital trusts themselves, or indeed CEOs, I know you've worked with CEOs, what can they do, or what can we as a public or a business school do to focus on that, what you argue is a crucial element of management practices, what will make a difference in the future?
Absolutely. I think that there is a lot to do, and there is a lot to learn. So I'm not going to tell you that I have the perfect model for training physicians everywhere in the world. But what I have seen is that, first of all, what you need is this very general approach towards management. I think we put a lot of emphasis on the top layers of hospitals, and we think about the training of CEOs, or as in the NHS, which is the case that I studied the most, moving CEOs from hospitals to hospitals, hoping that just one person alone can change everything. So I can tell you that from my perspective, that is not an approach that I would like to be repeated, because it really disregards all the organizational inflexibilities, the culture, and the issues that Andrew just mentioned. What I think would be much more promising, and what I see organizations really being able to change, is when you have alignment between what, you of course, you need a good person at the top, but you need this good person to invest in the middle layers as well. Which means not necessarily teaching them finance or accounting, although it's important, but is first of all teaching the basics of continuous improvements, making decisions on the basis of data. And I think the most important one, I'm an economist, but as you can see, I've been converted to organizational behavior. You need to think about, these hierarchical barriers that often exist in medicine are a real issue. Typically, who has good information about the patient doesn't really enjoy a hierarchical status. But we know that if we have cycles of improvements from the top to the bottom, and we can work on problem solving together, these are things that can really matter. So my ideal experiment would be to teach doctors how to be good team members. And by that, making them become also good managers. I'm telling you this from the perspective of a daughter of an orthopedic surgeon and the sister of a hospital manager. So, these are tensions that I lived in my life.
I have to say, my wife is an NHS consultant, and I see exactly what you're saying. Certainly, speaking of hierarchies, infectious disease has risen quite a bit in the hierarchy as a specialty, and it's striking how much more junior doctors are taking on, not only in their clinical responsibilities, but in organizational responsibilities. At least a hospital I won't name that I know that I happen to have firsthand or secondhand information about. The rotas, all of the schedules for all of the doctors are actually developed, including the senior consultants, are developed by the junior doctors, which is a bit of a revelation to a lot of very important people, shall we say. So hopefully some of that, the changes in hierarchy will hold, which, as you said, is often a function of complex and stable systems, but can work against you otherwise. But if there's any value to stability in this case, it is in the routinization of some of these processes that organizations have already engaged in. Nicos, to your point, back to the point about what should we expect, as well as just any responses to the previous comment.
I mean, I'd like to add one more dimension. I totally agree with Raffaella about the point that middle management in particular and doctors especially would benefit from being better trained on operations, continuous improvement, data-driven decisions, but also they need to understand the organizational context. But I would also add one more dimension, which is technology. And the use of technology in the crisis has accelerated the use of technology. I mean, one example is GP practices, primary care. I mean, the deployment of video phone consultations happened pretty much overnight. And I know it's been an initiative that people have found difficult to implement for at least a couple of years before the crisis. And I think that's one example of a change that happened in response to the crisis that's there to stay. In response to clearing the backlog, I think inevitably we're going to have to think about optimizing pathways in ways that use technology more effectively, and barriers to this adoption of new technology and change of pathways will be reduced because there's no alternative. So in a sense, I think, in addition to everything else that was mentioned, I think Andrew and his point about risk management, I think they're all important, but I think technology is another important dimension that's going to change after the crisis in ways that wouldn't have been possible without a good crisis.
And Rajesh, may I add one point on this? It's probably important that technology also changes in a way that complements the doctors rather than adding burden. This may be more of an issue in, when you have privatized hospital systems where technology is there really for the billing more than for the operations. But I think that there is also a lot of reflection to do on the creation of technologies that, instead of creating additional tasks, can actually remove some of the burden from the doctors, such that they can focus on the activities where their knowledge is really important, or the feedback from technology is very important.
Yeah, and I'm sure issues around privacy and other things will also come up, which inevitably does come up with technology. But as an example, I was talking to a colleague from Accenture who pointed out Accenture was one of the companies involved in rolling out Microsoft Teams in the UK NHS system, and that happened in 2 weeks flat, in the middle of all of this, right? And of course, the NHS has been trying various giant IT approaches for a long time. And so in that sense, the crisis has been a useful thing. And to your point, Raffaella, intuitive and more, helpful rather than something to have to confront yourself. A question related to that, and since you mentioned the private system, the question is that, let me just go back to how will the relationship between the NHS and private healthcare providers be impacted, if at all? So of course, many private healthcare hospitals were sort of requisitioned by the NHS during the peak of the crisis. And there's always some uncertainty about the relative level of privatization involved in this country. Any responses on that point about the relationship between private healthcare and the NHS?
I must tell you, Rajesh, I haven't seen anything yet which has indicated that this is going to be shifted in some way, or that something more fundamental can happen. Everybody responded to the crisis, it's unprecedented, we've got to change everything. But I haven't seen anything which indicates a change there. Okay.
I've seen some interesting, not from the NHS really, but there are two things that come to mind. One could be a positive change for the better, and one could be a potential threat to NHS. The change for the better is that we've seen the examples of countries that responded well. I'm thinking about Germany, I'm thinking about South Korea, which were characterized by a very interesting cooperation between the public sector and the private sector. And so there, especially if you think about those demand surges and the backlog that Nicos was mentioning before, being able to leverage that capacity could be really important. So definitely, if nothing has happened there to improve the governance of these relationships, maybe something should happen now. The thing that is a little bit tricky here is, if we don't improve the way in which the staff of the NHS is compensated or treated, my only concern would be that the private sector could be sort of a competitor for human capital, or for especially on the nursing side. And so, again, this doesn't need to happen necessarily. It's something that can be worked out through governance, but it's really important to think about what are the outside options of staff that works for the NHS. And given the enormous amount of effort and stress they've been through, I know that there is also a lot of intrinsic motivation that goes into working for the NHS, but I think that's exactly right why the NHS needs to up their ante in terms of HR management.
There are a few questions that are directed directly to each of you based on your comments. I'm going to take those next before we move to a few others. Andrew, you mentioned the importance of AI and the potential possibilities that exist there. Can you elaborate with a few examples, please?
Well, Nicos, I think, gave one in relation to appointments and so on, and remote appointments, and clearly that's been a big shift and very, very important and welcome. But it seems to me also that if I look at the question of sharing information, the ability, for example, you don't have to have a conference, and travel hundreds of miles. You can actually share experience at a Zoom meeting set up at 10 minutes notice. You know what I mean? That kind of thing, which is, it's not so much the particular application as an attitude to technology, which says things may be possible. Can I also give you, I'll give you an example. I'm taking from
Yes.
myself, okay? I mean, I found this book, Deep Medicine by Eric Topol, which was recommended to me by one of the, you know, a technology company, which looks at the application of this in medicine. And what's clear is there is enormous possibilities here in many different fields. The conclusion, I should say, by the way, of this book, anybody who hasn't read it, is, you know, it's not that people will be out of work, it's that doctors will be able to spend more time with patients talking about their problems and less doing paperwork and stuff like that. So again, I would regard that as a very important potential implication of AI.
And that, again, is an example of the kind of facilitating technology that Raffaella was referring to. Nicos, I know you teach many of our data analytics classes, and you teach things related to AI, machine learning, etc. And you're an expert in healthcare management. Any reflections on AI there?
I mean, you know, if you use AI as sort of, you know, an umbrella term to mean sort of, you know, any sort of data science and sort of analytics, I think it has a huge amount of potential. But if you use sort of, you know, AI in the narrow sense of algorithms that train on data and learn to think for themselves, I mean, I would agree with the premise that this has a huge amount of potential. But my personal view is that this potential is not close to in time to being materialized. So I think, you know, the era where we will have, say, you know, autonomous systems doing a diagnosis and replacing, say, human decision makers is not around the corner. But the era where information systems perhaps deploy an element of artificial intelligence may assist physicians and perhaps in note keeping, perhaps in sort of, you know, making recommendations and checking that no obvious mistake has been made in things like medication, dosage, and so forth. I think this is coming sort of, you know, in the next decade or so. So I would agree with Andrew's point that the value of AI in the short term is in complementing and scaling up what people do and leaving more time to do more value-adding activities as opposed to sort of the more menial activities that can be automated.
So are you saying that the stories, you know, about how radiology is now all being automated and over time more and more specialties will become that way, a disruption like this with COVID, could that put a pause to those kinds of things? Is that what you're saying? Because there's complementarity and there's substitution.
I mean, my view, maybe it's a little contrarian. I mean, radiology has made some strides, but radiology is one of those aspects where of medicine which is easier to codify by artificial intelligence than others. I mean, even before the crisis, I didn't see AI as being a disruptive force in medicine. I saw it as a complementary force to what physicians do. And I haven't seen anything to suggest that the crisis has changed this in any significant way.
Okay. A few questions about what this current situation and everything you've described implies for others. So whether it is management education providers, given all of the comments you had made about management and the importance of management, but also others in industry, and where you think there might be the greatest opportunities. Clearly, there's opportunity for executive education, or at least a joint MBA program or something of that sort. But where else are there opportunities to support hospitals with the changes that you have each referred to? So so is it in technology? So if I'm an entrepreneur today, is healthcare one that I should be pursuing? And if so, where? Any other industries?
Absolutely. I'm happy to tell you one story, which I think signals the really important learning that can come from industry into healthcare. There is one chain in one hospital in the US called Virginia Mason, which today is one of the leaders in lean adoption. And it's considered to be an example of a fantastic organization in many respects. But you know, the lean transformation for Virginia Mason happened after they visited the Toyota plants. And I think that it comes down to the realization that certain processes, especially processes that have to do with coordinating experts and making sure that the knowledge that exists in different pockets of the organization can come together, those type of processes have particular importance for healthcare. So my sense is that if you are a person that believes, you know, that has had experience in making a team of engineers and marketing people work together, chances are you might do great for a hospital, because, you know, the type of tensions that you might have encountered there exist. And that counts also for technology development, I think. A lot of companies these days are dealing with the creation of new technologies and new processes that allow them to deal with this massive uncertainty, also on the demand side. And I would expect some of these innovations to be portable also in the healthcare sector. Healthcare is unique in many respects, but it's also another industry, just like others in many other respects.
Thank you very much. I noticed that we're at the end of our time. The time really did fly, and I lost track almost. Thank you each for enlightening us, helping us look under the headlines, behind the headlines, at actually what is happening, and the very important management tasks that need to be completed. So Andrew, Raffaella, Nicos, we're all very grateful for your help. On behalf of the Wheeler Institute, let me thank you. Before we go, I have a couple of announcements about upcoming webinars of the Wheeler Institute. As you know, this is the 5th of 5 UK-focused COVID-related webinars. We have several exciting webinars coming up. Very soon, there's a talk by actually Raffaella's colleague, Rebecca Henderson, on rethinking capitalism. So, actually, Rebecca wrote the book even much before COVID, but some of the ideas there are even more relevant today as they were before. And Yanis Ioannou, our colleague in strategy and entrepreneurship, will talk about, who's an expert on the role of business in society, will speak with Rebecca about that. Tony Wheeler, please do join us for this one as well, a very special one for us at the Wheeler Institute. Tony Wheeler, founder of Lonely Planet, talking about the future of travel. And among others, Daron Asemolu about technological progress. Lots more webinars, both past, present, and future, available on our Wheeler Institute website. Thank you again to each of you who joined us, and thank you again to our panelists.